When we do actually not expect an atrial septal defect, how can we become aware that there may be an atrial septal defect in a patient when we do our echo? So the key finding is the enlarged right ventricle. A large right ventricle with well-preserved function indicates that there is volume overload of the right ventricle, and as soon as we see right ventricular volume overload, one of the most frequent diagnoses is atrial septal defect. Of course, this can also be tricuspid regurgitation or pulmonary valve regurgitation, but they are less common as primary disease, and we will always carefully look for atrial septal defects. If we cannot find a primum or secundum defect by TTE, the next step will always be a TE to look for a sinus venosus defect. How do we measure the right ventricle? As we have seen in the examples, it of course starts with eyeballing, and we compare the right ventricle with the left ventricle, and the left ventricle should in the four-chamber view normally be larger than the right ventricle. By measurement in a normal sized patient, we would expect that the diameter of the right ventricle measured somewhere between the basal and the mid third of the ventricle, between 20 and 40 millimeters. Another hint to think of an ASD can be the elevated flow in the pulmonary artery. Of course, one has to be careful that this is not mistaken with pulmonary stenosis, but in case of a normal pulmonary valve, but increased velocity indicating increased flow in the pulmonary artery, this can be one hint for a significant shunt in a patient with atrial septal defect. Another sign frequently seen in patients with significant shunt is that we have more or less a dilation of the pulmonary artery. This is in a short axis view, the aorta, and severely enlarged pulmonary artery and pulmonary artery branches. How do we detect the shunt? In most instances, this can be easily done with color Doppler, at least for the primum defect and for the secundum defect. It may require that we go away from the regular four-chamber view and change our transducer position more or less to the middle, and see that we have then a more or less oblique direction of our septum and have a better angle of incidence, and this is better for the visualization of the defect, but also better for the flow detection, because we are now more parallel to the incoming flow from the left atrium to the right atrium. This is an example where we can nicely see the shunt in a short axis view. We see the aorta here, the interaortal septum, and high up in the interaortal septum we see this rather small ASD causing continuous left to right shunt, as demonstrated by the color flow. The subcostal view would actually be ideal for visualization of an ASD, for both for visualization by 2D and for color Doppler, because we have an ideal angle, as we see here in this four-chamber view. The difficulty is that in many adults it's difficult to get a good quality. We have a too large distance from the transducer to the heart, and this is more the view that we would use in children. In the adults, it's this modified four-chamber view, as I have indicated before. What are the difficulties in detecting the shunt? Of course, poor image quality. The angle is important, as I have referred to before. Low flow velocity of an ASD can cause a very weak color signal. There may be problems with a predominant inflow from the inferior IVC, and this can frequently cause misdiagnosis of an ASD, but can be avoided by careful positioning of the transducer and looking carefully at the flow, whether it's really coming from the left atrium or whether it's only parallel to the septum coming from the IVC up to the tricuspid valve. As mentioned before, shunt flow is dependent on the relation of LV to RV compliance, and in a patient with reduced RV compliance, for example in pulmonary stenosis, there may, despite of a large atrial septal defect, be no shunt, and in this case, of course, we will have difficulties to detect the ASD just by color flow imaging. Now, how about contrast echocardiography? We see here a contrast injection with clear bubble. It's a lot of bubbles that go from the right atrium to the left atrium. Now, actually, this is not proving that there is atrial septal defect. This can also be a PFO, patent foramen ovale. What is necessary for correct diagnosis is that we see the washout of contrast in the right atrium. Now, in this case, it's not entirely clear whether there is indeed washout. So this only demonstrates that there is an opening between the atria, but this can either be PFO or an atrial septal defect. In most instances, we don't use contrast echocardiography nowadays for the diagnosis of an atrial septal defect. 2D echo and color Doppler are mostly sufficient. How do we quantify the size of an atrial septal defect? If you have excellent image quality, this can, of course, be done by TTE in the adult population. In most patients, we will, if we really need to know exactly how large the defect is, and this is when we plan to do an interventional closure, we would rather use TEE as shown here on the right-hand side. In the TEE, we have an ideal way to evaluate the entire interatrial septum, see the morphology, and exactly measure the diameter. We will also look for the largest diameter, and we'll do this in 2 orthogonal plans when we report then the size. A 3D echo can, of course, be a nice tool to show the entire aspect of the atrial septum defect, the shape of the defect, the dimensions of the defect. However, for intervention, it's less important to see this entire aspect of the ASD, because for the eventual planning and for the definition of the size of occluder we will use, we need balloon stretching, and we will measure the balloon stretched diameter of the defect. So how would we quantify ASD? By just looking at the size of the ASD. As I mentioned before, it does not really give us an idea how much shunt we have, but in a patient without any other abnormalities, we can expect that as soon as the diameter reaches 10 millimeters or more, we will have a significant left to right shunt. Patients with an ASD between 5 and 10 millimeters have a rather small defect with, if there's no other abnormality, leads to a rather insignificant small shunt, and with defects less than 5 millimeters, we'll normally measure no clear shunt, and we'll have no enlargement of the right ventricle. We could also calculate a shunt ratio, the ratio between pulmonary and systemic shunt. This is shown in these images here. We measure the systemic flow either in the left ventricular outflow tract or at the valve level by measuring the diameter and calculating the cross-sectional area in this part of the heart here. And in addition, we use a pulsed wave Doppler to calculate the velocity time integral, and this will give us the systemic flow. We do the same in the pulmonary artery in a short axis view, measure the diameter of the pulmonary artery, measure with pulsed wave Doppler at the same site here the velocity time integral, and get the pulmonic flow, and the ratio between both will give us QP/QS, the shunt ratio, and as soon as we end up with a shunt ratio of 1.5 or more, we would call this a significant shunt. Of course, there are a number of errors that can occur in these measurements, and the more robust and reliable parameter will be the size of the right ventricle and the apparent right ventricular volume overload for clinical decision making. This will be better than looking just at these calculated numbers. How about pulmonary artery pressure? We have mentioned before that severe pulmonary artery pressure elevation is rather rare in patients with ASDs. This is from a study looking at rather young adults and a mixture of patients, and we see that the majority of these, 51%, had actually a normal pulmonary artery pressure, 30% had a modest elevation between 32 and 50 millimeters mercury systolic pressure, and 19% more than 50 millimeters mercury. These are numbers we found in our own population of patients where we did catheter interventional closure of the ASD, and what we see here is the percentage of patients with normal pulmonary artery pressure, and we can appreciate that patients in the fourth and fifth or even sixth decade, still 50% of them had a normal pulmonary artery pressure. Now going up in age, when you look at the patients with an age between 70 and 80 years, the vast majority of them have elevated pulmonary artery pressure. So there is on average an increase of pulmonary artery pressure, but most of the patients do not have severe pulmonary vascular disease. It's only a small minority of about 5%, rather young adults who develop severe pulmonary vascular disease, and this is quite in contrast to what we see for VSD and patent duct. What is the role of TEE? First of all, if we have suspicion of an ASD because of right ventricular volume overload, but we cannot find an ASD by TTE, we will always do TEE as a next step to make really sure that there is no shunt. We'll again, in particular, look whether there is a sinus venosus defect, and look at the drainage of the pulmonary veins. A very important role of TEE, of course, is when it comes to the question whether a defect is suitable for catheter intervention. Again, the size of the defect is critical here, and we will see more details about this evaluation later.